Atrial extrasystole, in other words premature atrial contractions, together with AV nodal extrasystole, called supraventricular premature contractions. The ECG criteria of atrial extrasystole are follow: premature PQRST complex, changed P-wave morphology, not changed QRS morphology, QRS is narrow, and incomplete compensatory pulse. Now look at this ECG strip from 24-hour ECG monitoring. In the beginning, we see the main sinus rhythm. After this, let's check the regularity by the evaluation of RR intervals. This 24-hour ECG monitoring program automatically calculates the RR intervals and heart rate in the top of this ECG. As you see, during the sinus rhythm, RR intervals are almost equal to each other, so rhythm is regular. After this, we see the complex, which appears earlier than usual sinus complex and makes the rhythm irregular in this part. Look closer to this complex. It has negative P-wave with unchanged QRST. For evaluation the prematurity of this complex, let's measure the usual PP interval and compare it to our PP interval in irregular part. So you see that this irregular complex appears earlier than predicted sinus complex. So we have the first criteria of premature atrial contraction. Next step is comparing the sinus P-wave and premature P-wave. In our case, premature P-wave has opposite direction according to the sinus P-wave. So the P-wave morphology is changed and the second criteria is present. Now compare the QRS complexes. As you see, they are identical. QRS in premature complex is narrow and equals 60 ms, so the third criteria is present. And the last criteria, the compensatory pause. For this, let's remain the extrasystolic terminology. Interval from the sinus P-wave to extrasystolic P-wave called coupling interval. The interval from the extrasystolic P-wave to the next sinus P-wave called post-extrasystolic pause. Together, they form the compensatory pause. Compensatory pause called complete when it is equal to two usual sinus RR intervals, and therefore compensatory pause is incomplete when it is less than two usual sinus RR intervals. In our case, RR interval is equal 0.92 second. According to this, the two RR intervals are equal 1.84 second. That is much bigger than compensatory pause in our example. As a result, the compensatory pause are incomplete. So all criteria of premature atrial contraction are present. Let's explain all criteria one by one. According to the literature, the common theoretic mechanism of atrial extrasystole are abnormal automaticity and re-entry mechanism. If you want to know more about this mechanism, let me know in comments below. Generally, P-wave morphology reflects the direction of atrial depolarization, and it is positive in lead when it is projected to the positive part of this lead in hexaxial diagram. It sounds a little complicated, but the key message is that the P-wave reflects the direction of atrial depolarization. And vice versa, if the P-wave changes direction to negative in this lead, it means that it is projected to the negative part of this lead in hexaxial diagram. Thus, in this complex, the atrial depolarization went in opposite direction compared to the sinus impulse. As a result, this atrial extrasystole has lower atria origin. If the extrasystolic P-wave is negative in the second, the third and AVF leads, it indicates the lower atria origin of premature atrial contraction. If the P-wave is low amplitude or biphasic, it usually indicates the middle atria origin. And if the P-wave has minimal changes compared to the sinus P-wave, it means that origin of extrasystole is near to the sinus node. QRS complex represents the ventricular depolarization. As you see, ventricular depolarization goes in usual order, just like during the sinus rhythm. This is the reason why premature QRS complex is identical to the sinus one. But sometimes extrasystolic impulse is so premature that it finds the AV node in refractory period. Therefore, it can't be conducted lower to the ventricles. In this case in ECG, we see only premature P wave without following QRS-T complex, and it is called blocked atrial extrasystole. But in some case, impulse from the extrasystole conducts through the AV node but find the one of his branches in refractory period. Usually it is right bundle branch due to its natural longer refractory period. So in this case, right ventricular depolarization goes like in case of right bundle branch block, and QRS complex is wider and has right bundle branch block morphology. This premature atrial contraction called aberrant. We have another videos about the right bundle branch block and aberrant conduction. The link will be in description. Now to compensatory pause. Every time when the impulse comes out from the sinus node, the sinus node starts to prepare another impulse for the next contraction, just like charging the battery. And when it fully charged, sinus node creates the next impulse. But when the atrial or any other supraventricular extrasystole occurs, impulse from extrasystole reaches the sinus node during the preparing period and resets it. So after resetting, sinus node need to start preparing the next impulse from the bottom. And only after full preparation, impulse comes out from the sinus node. As a result, we have a pause that are equal to one full preparation time, or RR interval, and one reset preparation that in any case is less than usual RR interval. So together, they are less than 2 RR intervals, and this explains the incomplete compensatory pause. There are many types of atrial extrasystole. Couplets is 2 consecutive atrial extrasystole. Atrial bigeminy is when the every second complex is atrial extrasystole. Atrial trigeminy occurs when every third complex is premature. Quadrigeminy when every fourth complex is premature. Also, as we have already mentioned, there is blocked atrial extrasystole due to AV nodal refractory period, when we see only premature P wave without following QRS-T. And another form of atrial extrasystole is aberrant extrasystole, due to his bundle branches refractory period. Commonly QRS in this case is wide and has right bundle branch block morphology. But it also can have another QRS morphology. Please note, extrasystolic P wave can be merged with the previous T wave. PQ interval in atrial extrasystole can be in normal range, but it also can be prolonged, when extrasystole reaches the AV node until it's fully recovering from previous impulse, and it conducts the impulse slower, as in this example. PQ interval also can be shorter than in normal range, in case when extrasystolic origin is closer to AV node than the sinus node. So why the atrial as well as supraventricular extrasystole is so important? According to the data, supraventricular premature complexes are an independent predictors of atrial fibrillation and consequently ischemic strokes. Let's explain how it works. Frequent supraventricular extrasystole, which includes atrial and AV nodal, can cause asymptomatic atrial fibrillation. But what does it mean frequent? How many they should be? Frequency of any extrasystole is evaluated by extrasystolic burden, in our case premature atrial contraction burden. That is calculated by dividing the number of extrasystole by total heartbeats number during 24-hour ECG monitoring and multiplying by 100. And if the premature atrial contraction burden is greater than or equal to 0.4%, it is an independent risk factor for the incidence of atrial fibrillation. And in its turn, atrial fibrillation lead to left atrium thrombus formation. Thrombus can leave the left atrium and become embol, that obturate the brain vessels and lead to ischemic stroke. On the other hand, the atrial extrasystole lead to electrical changes in atria tissue that called electrical remodeling and structural changes that called structural remodeling. Both of them favor the atrial fibrillation formation, embolization, and strokes, and lead to tissue fibrosis and left atrium enlargement. As a result, patients with premature atrial contraction burden greater than or equal to 0.4% have a greater risk for developing or having atrial fibrillation. In this case, repeated or prolonged ECG monitoring should be performed for the atrial fibrillation detection. If you like the content, press like and subscribe to our YouTube and Telegram channel, and have a good day!